he has done his MBBS and MS from GMC Nagpur, MCS from Lokman Tilak Medical College Mumbai, and currently professor and head of Department of Plastic Surgery at the Medical College. And we will be discussing about breast, oncoplasty, and cosmetic surgery of breast.
Thank you, Dr. Sanjay, respected chairpersons, senior members of AMA, and dear delegates. My topic is oncoplastic and cosmetic breast surgery. Although it is a very vast topic, and because the CME focuses on malignancy and cancer basically, so I'll be covering oncoplastic more and just a reference to cosmetic breast surgery. So when we see breast malignancy, then surgical procedures for breast malignancy for removal of the tumor, there can be of two types. One is the breast conserving surgery and second is the mastectomy. Breast conserving surgery, when we call it a breast conserving surgery, when at least some part of the breast tissue is left behind and the tumor is removed. Whereas we all know in mastectomy, either a simple or a modified radical or a radical mastectomy, the entire breast tissue has been removed. So the reconstruction of the breast depends upon the type of surgical procedure which has been used for removal of the tumor. Why do we need to reconstruct the breast? It's basically the psychosocial aspects are important because the body image disturbances associated with woman's identity, sexuality, self-esteem, and psychological distress. There was a study recently by Indian authors and published in Lancet in a tertiary care center where they followed up on patients with who have undergone breast cancer surgery, and they found that around 28% had depression, 31% had anxiety, and around 25% had stress in the follow-up phase of after undergoing breast cancer surgery. So this is one of the factors why we need to counsel the patients regarding reconstruction of the breast. Now, by definition, breast oncoplastic surgery is complete removal of the tumor with a concentric margin of surrounding healthy tissue with maintenance of acceptable cosmesis and has to be mandatorily followed by radiotherapy. Now, it involves basic integration of plastic surgery techniques for immediate reshaping after white excision of breast cancer. But the basic principle, as Dr. Swapnil has also emphasized, there cannot be any compromise in oncological principles for removal of the tumor just to maintain the shape of the breast. We cannot do that. So that has to be followed properly. There are many problems in breast conserving surgery. Even we are rarely doing breast conserving surgery because in spite of the extensive evidence now available to support breast conserving surgery, still remains unpopular. Patient, when comes to the OPD, surgeon tells her about breast conserving surgery, it's a doctor sahab pura hi nikal dijiye. So that is still the thought which is prevalent in our patients, and they're not ready to accept. That is what I feel, because rarely we see patients undergoing breast conserving surgery, at least in our city. A close follow-up is required. That is a problem, and mandatory the patient has to undergo radiation, which may not be approachable to many. Even in our medical college, we still have a cobalt machine which gives radiotherapy. So advanced radiotherapy is not available. I distinctly remember a village doctor telling Dr. Kamal Singh around 15 years back कि रेडिएशन तो मैं अपने क्लिनिक पे ही दे देता हूँ, डॉक्टर साहब एक 200 वाट का बल्ब लगाता हूँ और उसको पेशेंट की तरफ फोकस कर देता हूँ. And obviously, as expected, he was kicked out of his clinic. So that is a state of affairs still prevalent in our country. So the problems are there for breast conserving surgery, and a comprehensive multi-speciality team procedures. Principles which are followed in oncoplastic surgery. If we see these two females, the breasts are different. One has a small breast size and the other has a large breast size. So if these two patients have a similar size of a tumor in a similar location, probably the surgery would differ in both the patients, because to maintain the conformity of the breast, we'll have to adopt different procedures for these two patients. So the breast volume is important. How much tissue is being excised is important according to the volume of the breast. What is the location of the tumor and glandular density? We'll see one by one. Location of the tumor. obviously the upper outer quadrant is the most common site of the tumor, is a favorable location for doing a breast conserving surgery with regards to the cosmesis which we can achieve in the post-operative phase. And the lower inner quadrant is the least favorable because we have the least amount of tissue available over there and will give the maximum deformity if we go for a breast conserving surgery. Excision volume, again, as compared to the breast size, if we excise more than 20% of the breast tissue, we have to go for advanced procedures for reconstruction of the breast. That we'll see the levels which are there for oncoplastic breast surgery. Glandular density is important, which we can assess both clinically as well as radiologically by mammography. Because in larger breast, obviously the fatty tissue will be more. Fat is always less perfused structure. So we have to decide what type of a mobilization of the breast tissue we can do to reconstruct the breast once the tumor has been removed. So a oncoplastic procedures into basically two types: volume displacement, which means we are not adding any tissue to the breast, and we are just rearranging the tissue of the same breast to achieve a reasonably good cosmetic outcome. So it is again level 1 and level 2. Level 1 is only 20% or less of the breast tissue has been removed, whereas level 2 is 20 to 50% of the breast tissue has been removed. So in level 1, we'll just arrange the breast tissues on and achieve a result. And in level 2, we'll have to adopt certain plastic surgery principles which are used for reduction of the breast and reconstruct the breast. And mostly this will require symmetrization procedure on the normal breast also. Now, volume replacement is when more than 50% excision has been done. Dr. Swapnil has shown one excellent case where more breast tissue was excised and a flap was done. So there was some breast tissue remaining, and additional cover was given with a flap so that the breast was properly reconstructed. So we need to transport tissue as seen in these pictures. There is a latissimus dorsi flap which has been raised along with the skin island, mobilized up to the axilla and rotated into the breast. The picture of the patient shown over here at a primary closure probably of a excision of the tumor, and the deformity of the breast is still there. Therefore, she'll require addition of tissue to maintain the contour of the breast. So various flaps locally which are available are latissimus dorsi flap, thoracodorsal artery perforator flap, and a lateral intercostal artery perforator flap. These are all local flaps, pedicle flaps, which can be done to reconstruct the breast locally. This is how a decision has to be taken. If it is a small or a moderate sized breast, then maximum 20% excision can be done to maintain a good cosmetic outcome. And in a large or a ptotic breast, we can even reconstruct after a larger excision also. Now, level 1 oncoplastic surgery, in which tissue rearrangement is done in the same breast, has certain principles. That is well shown in this figure. There is dual plane undermining. That means there is first undermining between the skin and the breast tissue. Then after the mobilization is done, then the tumor is excised and then the breast tissue itself medially and laterally is mobilized, and then it is brought together in the approximated together, and then closure is done. So basically, this is the surgical principle of doing a level 1 oncoplastic breast surgery, where same breast tissue is utilized to reconstruct. According to the location of the tumor, several approaches are there. This is a crescent mastopexy for tumors which are present on the upper pole of the breast and not involving the nipple areola complex. This is a B-flap resection in which there is a central tumor in which we have to do a nipple areola resection has to be done. So in this, what is done? A skin island along with the pedicle of the flap is used to reconstruct the areolar part, and it can be done only in patients who are having a moderate or a large size breast. And later on, the areola can be tattooed to give the appearance of the areola, and nipple reconstruction can also be done later on. A donut mastopexy is a very versatile technique in which a circumareolar incision is given and we can access all quadrants of the breast, but it's mostly used for the upper and lateral quadrant tumors of the breast. This is a racket mammoplasty in the upper outer quadrant tumors. What we can see is there are some small things which have to be done. This is a de-epithelialization of the areola and the nipple, which is done on the medial aspect, so that there is no lateral pull of the nipple areola when this closure is done. This is a V mammoplasty. It's for lower and inner quadrant tumor, which are the most difficult part to reconstruct because of least amount of breast tissue which is present. So this is for lower inner quadrant tumor. Mostly such tumors will require a level 2 oncoplastic procedures. Again, a J mammoplasty for lower lower outer quadrant. This is how the skin flaps are mobilized both on the both upper and the lower part, and they are closed in the midline. Now we come to the level 2 oncoplastic surgery, in which around 20 to 50% of the breast tissue has been excised. Now, all these procedures will result in a smaller, higher, and a rounder breast because there is a large excision of the tumor. And once we reconstruct the breast, it will have a smaller size. So basically, the opposite breast will need a symmetrization procedure to make both the breasts look similar. This is an inferior pedicle mammoplasty. There is a tumor on the upper half of the breast. We mobilize the nipple and areola on the inferior pedicle and then reconstruct. This is a superior pedicle mammoplasty. On the superior pedicle, and then the medial and the lateral flaps are brought in the midline, nipple areola sutured on the new location, and the opposite breast symmetrization has been done by a similar procedure. So these are for larger excisions in which 20 to 50% of the breast tissue have been excised. Now this was when only tumor excision is done or some part of the breast tissue is remaining and we can utilize it for reconstruction. Now we come to breast reconstruction after mastectomy. Now breast reconstruction after mastectomy can be done immediately after the excision of the tumor on the same sitting, or it can be a delayed procedure after the patient has undergone adjuvant therapies, and later on, once the patient is free of the disease, there is no recurrence, there is no distant metastasis, she can undergo reconstruction. There can be an implant-based reconstruction where we can use silicone or saline-filled implants to reconstruct the breast. But in that case, we need a good quality skin for placing the implant underneath. It can also be a flap-based reconstruction where low flaps are utilized to reconstruct the breast. A flap can be combined with the implant to reconstruct the breast. And in all these procedures, once we have reconstructed the breast, it is very, very difficult to achieve symmetry in a single procedure. So the now this is a very unique case when a patient who was having a young female having cystosarcoma phylloides was operated somewhere 1 year back by this incision, and this was the deformity she was having. I just put this picture to show the usefulness of an implant. Now we have two options for reconstruction in this case. One is a fat transfer, which might need multiple sittings because autologous fat transfers, always the fat gets resorbed somewhat. So we put a silicone implant in this patient, and we can see the result after some time, and almost the two breasts look similar. Hardly can make out the difference. So this is the importance of implant-based reconstruction. When we have not used any other flap, we have only used the implant. Now, breast reconstruction after mastectomy with flaps. Now, tram flap or the transverse rectus abdominis myocutaneous flap is a workhorse flap. It has been used since ages, but the problem with the tram flap was that the whole rectus muscle was elevated along with the skin and abdominal fat, and this led to the weakness of the abdominal wall and resulted in ventral hernias in the patients. So now with the advent of microsurgery, we harvest the skin and the subcutaneous tissue of the infraumbilical part, along with the supplying vessels, and then anastomose here with the either the internal mammary artery or the thoracodorsal artery. There are various other flaps also which can be used, like superior gluteal artery flap or the inferior gluteal artery flap for reconstruction of the breast. Now, this is the case we did breast reconstruction with a deep inferior epigastric perforator free flap. So this patient had a tumor here on the left breast, a large tumor. She had to undergo a modified radical mastectomy. This is the outline of the flap. These are the markings of the perforators we have marked. Either they can be done with a color Doppler or a handheld Doppler also. This is after the flap has been elevated. This is the perforator which is coming from the deep inferior epigastric artery. This is the exposure of the internal mammary artery after removing the costal cartilage on the chest. Internal mammary artery, as you all know, is also used in coronary artery bypass. And anastomosis was done with the internal mammary artery of the deep inferior epigastric artery. This is the on-table picture after the thing. And the advantage of this procedure, especially in patients who have had children, is abdominoplasty has also been done. This is a post-op picture after a month, after 15 days, I think. The flap is well settled, but now what the patient will require is reduction of the right side breast. Now we come to cosmetic breast surgery. Now, cosmetic breast surgery, there are mainly two procedures: breast augmentation and breast reduction. There's also mastopexy. We do gynecomastia surgery for male patients also. But mostly breast augmentation and breast reduction are the two most commonly done procedures for breast augmentation. Now we come to breast augmentation. The breast augmentation is done by two means. One is breast implants and the second is autologous fat transfer. So breast implants are of various types: the saline-filled implants, silicone gel-filled implants, and the textured implants. Placement of the implants can be either between the breast tissue and the pectorals, or it can be subpectoral. It depends on the indications of the and the profile which the patient wants. But mostly the placement of the implant is done between the breast tissue and the pectorals, and it gives a more natural look to the breast. This is autologous fat transfer. The fat is harvested from the anterior abdominal wall or the thighs, and then the fat is injected into the breast. So basically it is a fat graft, like we do a skin grafting. This is also similar procedure like that. But the problem is autologous fat transfer, there will always be some resorption of the fat. So we might have to repeat the procedure after 3-4 months. So these are the two basic procedures which are used for augmentation of the breast. This is a young female who came to us with a small size breast. We did breast augmentation with silicone implants. There are three approaches which can be used. One is the axillary approach, second is the circumammary approach, and third is the inframammary. Mostly the inframammary approach is used because it is easier, and once the implant have been placed, almost the scar is invisible. Another patient with small breast have undergone augmentation with silicone implants. Now we come to breast reduction procedures. Why is breast reduction required? It is in very large breast. There can be shoulder pain, there can be cervical and upper thoracic backache. Patient can be severely embarrassed both physically and sexually. There can be recurrent skin infections because of very huge breast. And another indication, as I've already told, is for symmetrization with opposite breast in oncoplastic breast surgery. This is a very unique case, unique indication for breast reduction. This patient we had operated around 15 years back in medical college. She had a very hypoplastic left breast, so we placed a breast implant on the left side. Now what happened? She got married, she had children. Since there was no gland here, this breast did not hypertrophy, but this breast hypertrophied. So after so many years, she came because of the discrepancy in the shape of the two breasts. Now what we have to do is we have to reduce the size of this breast and do a reduction mammoplasty on this side, which will correct the ptosis also and symmetrize both the breasts also. So this is a unique indication of breast reduction which I saw recently. Various procedures, principles are there for breast reduction. Basically, we have to do it in two-dimensional way. One is the vertical resection, second is the horizontal resection. Only then we can get a good result. And there are certain surgical details. They're quite complex. Even we took several years to understand them. Development of the nipple areola complex is very important because the most dreaded complication of doing a breast reduction surgery is post-op necrosis of the nipple areola complex. What if that happens, then the surgeon is gone. So there are various techniques of breast reduction surgery. Basically, they are based on the orientation of the pedicle carrying the nipple areola complex. So it can be an inferior pedicle technique, which is used for very large breast bleeding reduction. Medial pedicle technique is the most reliable and gives the best cosmetic result. And it can be used for moderate size breast, but it is difficult to use for very large size breast. Now, this is a procedure of breast reduction. The young girl having a lot of discomfort because of large size breast. So this is how the marking of breast is done for breast reduction. So this is the current nipple and the areola. The size of the areola is also large. This is the new position of the nipple and areola where it should be. And this is at the level of the inframammary crease. So this is how marking is done preoperatively in sitting position of the patient. And after that, the patient is taken off for surgery. This is the amount of breast tissue removed. This is how it looks on table. It looks quite horrible right now, but gradually things improve in such patients. It takes some time for the breast to achieve its normal appearance. This is another young girl. In fact, she was a medical student and she had very large breasts. And she underwent breast reduction. This is a picture at, I think, at 1 or 1.5 months post-operatively, and this is the picture around 6 months post-operatively. You will see the difference. There is a much more boxy appearance of the breast here, which has reduced significantly, and it takes almost 1 year for the breast to assume its normal shape. The size of the breast which we have, how much reduction has to be done, has to be decided by the patient. We take their opinion on how much reduction they want, and according to the cup size they want, we have to decide how much tissue has to be excised. So this is all about breast oncoplasty and cosmetic breast surgery. Thank you very much for a patient hearing, and thank you all for coming to this CME.